Good morning and welcome to today's webinar. On behalf of Boston IVF, we're pleased to host today's webinar, Recurrent Pregnancy Loss, presented by Dr. Sony Sierra of Trio Fertility in Toronto, Canada. Before we get started, I would like to go over a few quick items about today's event. First, all physicians in attendance will receive a AMA PRA Category 1 credit, and all other providers will receive a certificate of completion for 1 contact hour credit. Their certificate will be emailed to you by Harvard around midsummer. Now, without further ado, I would like to introduce today's speaker. Dr. Sony Sierra is a reproductive endocrinologist and infertility specialist and the Deputy Medical Director at Trio Fertility. For nearly 20 years, she has specialized in infertility and recurrent pregnancy loss and also serves as Medical Director at Evolve Egg Freezing Clinic. She co-leads Canada's largest early recurrent pregnancy loss program and is an assistant professor at the University of Toronto. A past president of the Canadian Fertility and Andrology Society, Dr. Sierra is widely published and active in leading fertility societies, including ASRM and ESHRE. Her work focuses on infertility, RPL, implantation failure, and PCOS, and she is known for her compassionate, patient-centered approach. We encourage you to submit questions to Dr. Sierra using the questions section of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the questions and answer session at the end of today's presentation. All right, we're going to get started. I'm going to pass it over to Dr. Sierra.
Hi, thank you, Alyssa, and thank you for the opportunity to be here and speak on recurrent early pregnancy loss. As you alluded to in that lengthy bio, it has been a career interest of mine for over 20 years, having trained with Mary Stevenson, who's now retired, but was at the University of Chicago for many years. So today we're just going to talk about the management of recurrent early pregnancy loss. And specific objectives, we'll define it, and then we'll review what our guidelines currently say, sort of comparing and contrasting across major societies in fertility. I'm going to outline evidence-based to the best that I can, diagnostic evaluations, and then discuss management strategies that are supported. I'm just going to give you guys a little insight into what we're doing up in Canada in terms of practice patterns and referral considerations. And then we're going to end by reflecting a little bit on guideline utility and limitations in a real world case. I'll try to do it all within an hour. Okay, so this is a slide that probably starts off most of my patient consults. One of the things that people don't always understand is that we are incredibly inefficient at making babies. So from all the conceptions that occur before we even know there's a pregnancy, almost 60% of them fail. And most of those pregnancy losses occur because of random genetic bad luck. So before a pregnancy, and this is really old data based on old ways of looking at genetics. So before 6 weeks of pregnancy, before the start of a fetal heart rate, it's about a 50% chance of loss, and almost 70% of those are due to random genetic bad luck. As pregnancies progress, of course, the risk of pregnancy loss decreases, but the risk of genetic issues still is persistent until we get to about 10 weeks, which is sort of the celebratory threshold when the risk of ongoing sporadic loss is about 2 to 3%, and the chances of an ongoing genetic issue are very low as well. So, sorry, I keep going backwards. I'll figure it out. So the risk factors for pregnancy loss, of course, reproductive aging, because we know majority of losses are genetic. And as we get older, there's more risk of aneuploidy due to faulty spindles. And there's an increased chance, 37% of early loss, clinical loss at age 40, and then over 45, it's extremely significant at about 65%. The other risk factor for pregnancy loss is not having, is having a previous losses. So there's an additional 10% of risk of loss with every subsequent loss. And there's a 42% with 3 or more losses. So recurrent early pregnancy loss goes beyond just an inefficiency of human reproduction to actually being a true diagnosis with a significant increased risk of further loss. So this is an old slide, but it does explain also nicely why the diagnosis of recurrent early pregnancy loss is separate from the inefficiencies of human reproduction. So this is data that was collected prior to 2000 that showed with every increasing loss, the chances of having a pregnancy loss with a normal embryonic karyotype increase. So therefore, with every loss beyond 2, there's a higher chance the couple or woman is losing an embryo that's genetically normal. So there might be something else going on. The other reason to consider recurrent early pregnancy loss as its own clinical entity is sort of the impact it has on the woman or couple. 40% of people will go through a typical bereavement process after one pregnancy loss, similar to having a stillbirth or a neonatal death. A nice work that came out of Copenhagen, because they collect large database information, 300 women with recurrent early pregnancy loss and 100 compared to 1,800 just trying to conceive naturally. They found that moderate to severe depression was reported in almost 10% of women with recurrent loss compared to those in the general fertility population of 2.2%. So there's an increased grief reaction. There's an increased risk of moderate to severe depression in these couples with recurrent early pregnancy loss. So therefore, how do we define it? So I guess the American Society, 2 failed clinical losses prior. Historically, it was 3 until just recently it was updated due to more evidence and previous guidelines, and the losses do not have to be consecutive. This sort of goes hand in hand with ESHRE's 2023 guideline that said recurrent early pregnancy loss should be defined as having 2 failed pregnancies with the pregnancy confirmed biochemically or clinically. And this guideline actually encourages evaluation after 2 losses, regardless of sequence. And that data comes from, again, Copenhagen large database studies that showed the chances of finding a diagnosis were equivalent whether you started diagnostic evaluation after 2 losses or 3 losses. So our most recent guideline, just published in 2025, also says that recurrent early pregnancy loss represents a history of 2 or more clinical pregnancy losses that we should begin evaluation after 2 losses. So the epidemiology, when we consider those definitions, are that it affects 1 to 2% of reproductive age couples. The important thing, and we'll talk about it later, is that this group, even though they have this significant history of loss and go through the emotional trauma of these losses, ultimately have a very good prognosis of achieving a live birth. And I think anybody who works with these couples should always remember this and encourage patients about that as well. And we know that the most common cause for early loss is aneuploidy. However, beyond that, beyond aneuploidy, there are other causes: anatomic, endocrine, immune, male factor, environmental, and about half of those cases still might be unexplained. So when it comes to genetics, it would be great to have products of conception, and all the guidelines suggest testing when 2 or more losses and obtaining products of conception for analysis when available. And they also suggest parental karyotypes. So we see balanced translocation in 2 to 5% of people presenting with recurrent early pregnancy loss, and therefore this is included across all guidelines to consider. Products of conception testing, I'm just going to speak to it briefly. There was a recent publication by Billy Coute that suggests that all guidelines should now be updated to include products of conception testing. And that's based on a nice little study. He participated with Popescu as the primary author. But essentially, they took patients who had 1 loss. They were managed expectantly, given encouragement. They tried again. When they had a 2nd loss, they had patients who went through and just the standard recommended recurrent loss workup. And they found that there was about 45% who found something, and 55% that came back with a normal loss. If that 55% also had products of conception that documented abnormal, then they could explain almost 91% of losses in that group. When they have both the recurrent loss workup and products of conception testing, again, they have an explanation for about 95% of people presenting with recurrent loss. And that was shown in the same paper to be financially a better option as well, just given the time and effort and cost of additional medication evaluation when really testing products of conception might tell you the whole story. So when there is a genetic issue, counseling is essential, and natural conception, again, is still viable with a good prognosis according to all guidelines. Now, I'll talk about pre-implantation genetic testing a little bit. So in the cases where we do know that there's a random genetic error in previous pregnancy losses, or in the cases of unexplained, there's some nice work done by Macklin early, over a decade ago, that showed it's better when he shows these because he shows you in real film. But essentially, they took two mouse models, one recurrent pregnancy loss, one normal. They were looking at the decidualization reaction in the endometrium. So when there's no embryo, when a high quality genetically normal embryo was placed in the normal model, there was a decidualization reaction. In the recurrent loss group, there was also a decidualization reaction. But when a low quality embryo was introduced to the normal fertile control group, there was no reaction. However, in the recurrent loss, there was. So it's almost like an abnormal sensor or an abnormal quality control mechanism where the recurrent pregnancy loss was having a decidualization or an implantation attempt, regardless of the quality of the embryo. So considering that, people have been looking for a long time at the role of pre-implantation genetic testing for aneuploidy or genetic issues in patients with unexplained recurrent loss. And the best summation of evidence comes from a recent systemic review and meta-analysis that looked at all of the studies when couples were given treatment after two losses, two unexplained recurrent losses. So they were given ART or IVF with PGT versus expected management. Interestingly, they found that patients in recurrent loss were not consistently making poor quality embryos, which is good to know. And they found that transfer of normal embryos resulted in similar live births and pregnancy loss rates in recurrent loss versus non-recurrent loss patients. So patients compared with standard IVF in patients with recurrent pregnancy loss, they did have a lower clinical loss rate and an increased live birth rate per transfer and per patient. So it is low quality. All of the studies included in this meta-analysis were heterogeneous. Some were randomized, some were not, and not every other treatable cause was ruled out. So there is low quality evidence suggesting that PGT may improve live birth rates in unexplained recurrent loss. However, we need our RCTs to give us a definitive answer if it does help. This is sort of the totality of evidence that was included, and just again, illustrative purposes. Clinical pregnancy rate was non-significant. Clinical pregnancy loss rate in some studies showed benefit with PGT, but overall not significant. And live birth rate, again, lower in RPLs somewhat, which is interesting, but not clinically significant. So all of our guidelines, and I don't believe the ASRM has addressed PGT, but it's not routinely recommended. ESHRE is very definitive in saying it's not routinely recommended. However, they say that this recommendation is based on limited evidence. And we in Canada suggest that they should be counseled that we don't have data to suggest a clear benefit for offering PGT when there's a history of recurrent loss over just trying to try on your own in terms of increasing live birth rate, reducing the chance of pregnancy loss, or decreasing the time to live birth. So moving from genetics to anatomy, uterine anatomy evaluation is extremely important, recommended by guidelines across. 3D ultrasound is seen as a good first-line investigative approach. Saline sonohystogram is an acceptable alternative, with hysteroscopy only recommended for confirmation or treatment. There's not a lot of data. Actually, there's very poor data to suggest surgical correction when a uterine anomaly is found. The best evidence we have for treatment is a septate uterus, and that comes from sub-analysis of the TRUST trial that was published in 2021. They just looked at live birth rate with septum resection, and they didn't have very many patients in the category for analysis with recurrent pregnancy loss. However, they did suggest that live birth rate with septum resection was not different from that seen with expected management. They didn't report separately for the recurrent loss. When it comes to adhesions, lysis of adhesions, we do see adhesions described more likely in patients with 2 or more losses, which makes sense because sometimes those patients have had repeated D&C or surgical manipulation. And one uncontrolled study showed some benefit in live birth rate in a very small portion of patients with 2 or more losses after hysteroscopic resection of those adhesions. Removal of submucosal fibroids, again, they see that submucosal fibroids are reported in about 8% of people with recurrent loss. There's small, old, uncontrolled data suggesting removal is helpful. So current guidelines, all women should have an assessment of the uterine cavity. However, there's insufficient evidence for septum removal. Sorry. Again, CFAS guidelines, investigations for uterine structural abnormalities should be considered based on good clinical practice as opposed to evidence. And while patients should be counseled that there's no clear benefit to routine surgical resection, again, should be made on a case-by-case basis in terms of clinical decisions. Oops. From after anatomy, we consider endocrine. So thyroid is important. If it's abnormal, the guidelines collectively state we should treat. Diabetes, we should optimize sugar control. Prolactin, if there is prolactinemia, it should be treated. And luteal phase deficiency is not a validated diagnosis. I'm not going to go through the evidence for all of these things, but I will tell you in general, it's not extremely strong because many studies haven't looked at people with recurrent early pregnancy loss as a subgroup with any power. I'm also going to state that with thyroid, we've gone back and forth as a specialty in terms of whether we should treat and screen for antithyroid antibodies, but current evidence suggests we shouldn't screen because there's no evidence to suggest that treatment of antibodies affects live birth outcome or risk of pregnancy loss. So at present, we treat if TSH is abnormally elevated, but otherwise no. Again, this is just going back to the management. The dopamine agonist for hyperprolactinemia is based on one study of something like 20 patients in 1980 that documented higher take-home baby rate in the group with recurrent loss that had hyperprolactinemia if they were treated. So again, very poor evidence. I'm just going to say something that the guidelines don't address separately, but there is an association with obesity and recurrent early pregnancy loss if we're talking about endocrine factors. There was a nice study done by Christina Boots in 2014, small, 322 patients with recurrent loss that had documented a euploid or a genetically normal loss. And they had found that the risk of a subsequent euploid loss was higher in women who were obese with a BMI over 30 compared to those that were non-obese. BMI over 24, actually, so just in the overweight category, was associated with increased risk of recurrent loss patients in a Chinese group. And overall, maternal BMI, therefore, increases the risk of loss in couples with unexplained recurrent early pregnancy loss and definitely should be addressed when you're investigating. PCOS, so this is based on about 1,000 of our patients. So we do see that 24.5% of people with recurrent early pregnancy loss also met criteria for diagnosis of PCOS, and that compares to about 11 to 12% in the general population. So there seems to be an increased finding of PCOS in our group of recurrent loss patients. And there was an increased correlation or positive correlation between PCOS and number of previous losses, where there was a 3.83% higher risk of loss in the PCOS group. Another sub-analysis that we did initially when we presented as an abstract is I do a lot of empiric metformin treatment in this population, and they did have a higher pregnancy outcome. And therefore, we're looking at it in updating the database and looking at it more definitively with more patients, but also considering if there might be a role for further study or a trial in that area. Also related to the endocrine system, progesterone. So we all know how important progesterone is in early pregnancy. I like this drawing. It's from 2001. It's from a nice review paper on implantation that was published in the New England Journal. But it really shows nicely the role of progesterone. So progesterone is so important when it comes to the vascular cascade and immunologic cascade that takes place to allow for the development of an early pregnancy in a healthy way. We also know from really old data in the 1970s and 1980s that if we removed the corpus luteum, which is the source of progesterone in a natural pregnancy, the pregnancy is lost. It's very critical to the maintenance of pregnancy until the placenta assumes function. And these data suggest the really important role in progesterone in the maintenance of early pregnancy. So for many years, a lot of us were just giving progesterone if there was an issue with early pregnancy loss. In about 5-6 years ago, there were 2 trials of first trimester progesterone specifically in the group with recurrent early pregnancy loss. And it came out of the TOMI network in the UK, which is a large network of recurrent early pregnancy loss programs. And so there were 2 trials. One was the PROMISE and second was the PRISM. I'm just going to go through them quickly because I find them interesting. So with the PROMISE, patients with recurrent early pregnancy loss who were trying to conceive naturally were given 400 micrograms of progesterone in the treatment group and a placebo in the comparison group, and they looked at live birth. They actually randomized 825 patients, which is extremely exciting because you never see those numbers in recurrent loss trials. But when they looked at live birth outcome, which is the most important one, they weren't able to see a statistically significant difference. Understanding this original graph that I referred to, in that with each subsequent pregnancy loss, there's a higher risk, the authors thought, well, maybe there's a dose-dependent effect. So looking at it based on number of previous losses, they did see that when there was 3 or more losses, there was a trend towards favoring progesterone. So they had a subsequent study designed, which was the PRISM study that looked at rescue progesterone. So first trimester progesterone in women who had presented with early pregnancy bleeding. And they powered this to look at the recurrent loss group separately. So again, the same intervention, 400 milligrams of micronized progesterone twice daily compared to placebo looking at live birth. And here they didn't find a clinically significant impact, but a trend to higher live birth outcome in the progesterone treated group. However, like I said, they powered it to look at the subgroup analysis to see if there was any improvement or any more significant impact with increasing number of pregnancy losses. And there they found that there was an increasing trend to favoring progesterone with an increased number of previous losses. So almost a biologic gradient is how they described it. This is the same information just shown in pictorial that shows that there seems to be an improvement in live birth outcome favoring progesterone with 3 or more losses. This is the totality of published trials on progesterone in terms of live birth or ongoing pregnancy in groups with recurrent early pregnancy loss. And when we look at it this way, again, these are poorly designed in terms of heterogeneous studies, but there does seem to be a favor towards progesterone. Drug safety was addressed also by both of these, and there didn't seem to be any issues. And when they distilled the numbers down and looked for number needed to treat outcome, they did see that in cases with 3 or more miscarriage, number needed to treat with progesterone was 8. So there was some benefit to giving progesterone. However, based on their definitions and outcomes, none of the guidelines can actually condone the use of progesterone across the board. So ESHRE said to consider it in women with 3 or more losses or early bleeding. ASRM states there's insufficient evidence. CFAS, we kind of went in the middle. We said it's optional and it can be beneficial when there's early bleeding present. Thrombophilia evaluation, there's many years of people testing for inherited thrombophilias, but currently none of the guidelines recommend it based on available evidence. But we do suggest testing for antiphospholipid syndrome. And antiphospholipid syndrome, again, just quickly, it's a diagnosis that's based on 2 positive tests of blood markers, 12 weeks apart, correlated with clinical criteria that include 3 or more losses, less than 10 weeks gestational age. And if antiphospholipid antibodies are found, they have a very poor prognosis if not treated, and a good prognosis if they're treated with low-dose aspirin and low molecular weight heparin. There was a Cochrane review done about 5 years ago that showed that heparin plus aspirin may reduce the risk of loss compared to that with just aspirin in this group with antiphospholipid antibodies. I mentioned inherited thrombophilias and recurrent loss, and we don't have any data that suggest there's benefit to treatment, even though there's some retrospective data that shows there may be associations of these in groups with recurrent loss. Immunological factors other than antiphospholipid, routine testing is not recommended by any of the guidelines. There's a lot of places, a lot of clinics, a lot of programs offering natural killer cell testing, peripheral natural killer cell testing. It's not supported by any of our guidelines or our evidence. And if we look at the evidence carefully for the use of IVIG in early recurrent pregnancy loss patients or intralipids or high-dose steroids, there is no evidence to support the use of any of that in this patient population. Male factor is interesting. So recently, there's been several meta-analyses that have demonstrated that sperm fragmentation is higher in groups with recurrent early pregnancy loss. But because the quality of the evidence is heterogeneous, small studies, not controlled, routine testing is not currently recommended. However, lifestyle optimization is. I think I'll speak to it a little bit later, but when we're seeing patients with a history of recurrent pregnancy loss and they first present, it's an excellent opportunity to have a conversation with patients, not just of medical risks, but lifestyle risks as well. And optimization, especially with respect to male factor, can be beneficial. Infection, chronic endometritis. So this is an interesting area. Different studies document different prevalence. So anywhere from 10 up to 30%. Biologically, it makes sense. If there's a chronic inflammation, there could be infiltration of plasma cells in the decidua, chronic inflammation, and decreased receptivity. And classically, we make the diagnosis with endometrial biopsy and identification of plasma cells and immunohistochemistry strains for CD138, which is a marker for plasma cells. So based on that technology, they saw that CD138 was helpful, and live birth rate in women with untreated chronic endometritis was 67% compared to the group without it at 87%. So it looks like it has an impact on live birth outcome. And they have seen that up to, again, 31% of chronic endometritis in this population of recurrent loss patients. So studies do suggest an increased prevalence. However, we don't have conclusive evidence regarding what to do when we find it. In other words, do we treat with doxy? Do we treat with levoflage? Do we test for cure? And does it actually have improved obstetric outcome? Other infections that people have in the history of recurrent loss treatment tested for ureaplasma, mycoplasma, chlamydia markers. But again, we don't have any evidence to test or treat. Uterine microbiome, it's an interesting ongoing area of data collection and analysis. It's based on some case reports done early in 2020, 2016 that show that lactobacillus is the most prevalent microbe found in the endometrium during early pregnancy, and the presence of non-lactobacillus dominated microbiota is associated with a significant decrease in ongoing pregnancy and live birth. And again, ongoing prospective studies are still taking place. I mentioned lifestyle factors. So smoking, we don't have data specifically in the recurrent loss population, but we know that smoking in the general population increases the risk of sporadic loss. Alcohol, we see a dose-dependent impact on the pregnancy loss risk. BMI, I mentioned obesity, but even extremes of underweight may impact pregnancy loss. And caffeine, again, there's a dose-dependent impact on the risk of sporadic loss, and we therefore recommend to keep less than 200 milligrams a day. So if we look at the guidelines as a whole, all three guidelines, European, Canadian, and American, suggest we do parental karyotype in the workup of these patients. We should be looking at products of conception genetic testing because it can, in addition to a workup, provide an answer in 95% of cases based on that one study. We should look at uterine cavity evaluation. We should look at basics of endocrine, thyroid function, hemoglobin A1C, prolactin. And we should test for antiphospholipid antibodies and not so much look at natural killer cells, thrombophilia, torch, or reflexively offer PGT. When it comes to management, again, treat underlying thyroid metabolic conditions, surgical correction case by case for cavity abnormalities, antiphospholipid antibodies we should treat with aspirin and low molecular weight, and we should also optimize lifestyle and offer supportive care. So again, I said I'd just give you a snapshot. So this was done by Vanessa Bacall at Mount Sinai and myself. We just wanted to see what's the current practice of recurrent loss across Canada. And we surveyed both members of the OB-GYN community and the REI community. We had 449 people access the English survey, and about half of them responded. Equally distributed in terms of years of practice. So 70% already were on board in terms of considering recurrent loss after 2 losses. 55% of them would include biochemical losses. And most of them didn't require the losses to be consecutive before consideration of recurrent loss diagnosis. And I should say that this was a survey that was done before the guideline was released in 2025. Assessment, over 80% were already looking at endocrine. REIs were more likely to order prolactin, and 85% of the general OB-GYNs were screening acquired thrombophilias, so antiphospholipid antibodies. REIs were looking more closely at other autoimmune, but our OB-GYNs in Canada were doing a really good job at the basic workup. Those who were in practice longer ordered inherited thrombophilia, which makes sense because those are old diagnosis or old ways of looking at recurrent loss. Most people looked at the uterine lining. 100% of the REIs looked at karyotypes. And products of conception testing was ordered about half of participants, with no difference between OB-GYN and REIs. Not a huge uptake or not a huge practice pattern to routinely do products of conception testing, but that has to do more with location. Canada is very spread out, and outside of the big cities like Toronto and Vancouver, it's really hard to get products of conception testing. Companies like iGenomics are making it better because they'll ship tissue collection kits wherever, but routinely or historically, it's been difficult to obtain. 40% almost referred to REI for further management, and 103 out of 200, so over 50%, were prescribing progesterone, most commonly Prometrium because it's easy to access. If they did make it to an REI office, PGT was offered by 87%, which is interesting, and about 80% were offering psychological support, which is encouraging. So when we look at the guidelines, just a few sentences on them. The goal of guidelines is to deliver high quality reproductive care, and it combines the best available scientific evidence with clinical judgment. However, when we have a guideline in hand, we still should be able to tailor care to complex individual patient needs. We would love robust, well-developed guidelines, but in recurrent loss, we don't have the data to make those guidelines. There's a lot of evidence that's poor, definitions are not uniform, there's very few well-designed clinical trials, and lack of standardized patients and treatment protocols. So again, it's really important to consider the patient sitting in front of you, their perspective, their experience, etc. Counseling for couples is important. I mentioned important at the start of a visit because we get that opportunity to talk about lifestyle, but also it's important to encourage these patients, providing the prognosis that 70 to 80% will conceive successfully. It's important to acknowledge their emotional burden, explain uncertainty when losses are unexplained. I mentioned when we have the genetics, it's important, but when we don't, 50% of the couple sitting in front of you, you're not going to have an answer for it. And then talk and encourage early pregnancy monitoring. About a decade ago, Musters did a really nice survey of patients with recurrent early pregnancy loss and asked them what they wanted. They want early and frequent ultrasounds. They want beta HCG to be monitored early, practical advice on lifestyle and diet. And I think that has to do with putting control back in their hands in an otherwise uncontrolled experience, offering emotional support. They want a clear policy with how the first trimester is going to be monitored. What they didn't find helpful is hospital admission, complementary medicine, and ultrasounds on a daily basis, which I don't think anyone's doing. So I just wanted to end by looking at a typical case. So this is a 36-year-old who's had 4 pregnancies, 1 take-home baby, and then 3 losses after the take-home baby. Never had a delay to conceive. All of the pregnancy losses had a very similar pattern. They got to 4 to 6 weeks just before an ultrasound was documented on ultrasound. Sorry, just before a heartbeat's documented on ultrasound, and all the pregnancies were lost either medically with misoprostol or expectant. She lives up north, so travel and being able to collect tissue wasn't an option. Workup was done locally, normal karyotype, normal endocrine workup, nothing found on autoimmune, normal cavity, no male factor. Last loss was on low-dose aspirin and progesterone empirically. She's really upset. She wants a family of at least 3 children. She's 36 years of age. Working up as per guideline and treatment was given as per guideline. So what would you do? And I think we all sort of work on the principles of what's biologically plausible and not to do any harm. And so just in terms of what would you do, I was hoping if there's any discussion to be had. I can't see anybody anymore. But if there is an opportunity for anyone to offer what they would do in this situation, I'd love to hear.
Hi, Dr. Sierra. We'll wait to
Hi.
see if anybody responds
Okay.
in the questions section or the chat.
Mhm.
Um, in the meantime, I do have one question that came in, and I was hoping to ask you that while we
Mhm.
wait. One of the questions is about unexplained RPL, and there's about 50% that's unexplained. Do you have any what diagnostic testings do you feel offer the highest clinical value for RPL?
In unexplained, so unexplained meaning you've already done the investigations or you're starting from scratch?
I don't have that here, but I'm guessing they're starting from scratch.
Okay, so if there's three or more losses, I do the routine workup that I talked about. So I would look at genetics, antiphospholipid antibodies. I would look at hormones. I would look at the uterine structure. In my practice, do routine testing for endometritis and microbiome, and I look at male factor. Which is going to give us the biggest yield? Again, it depends on the characteristics of the patient. So if someone's sitting in front of me at an advanced maternal age, we don't have tissue diagnosis, I'm going to be suspicious that we're losing pregnancy because of aneuploidy. Um, but I would still do other investigations to ensure that there were no other treatable causes, and then talk about how we can maximize their family planning in light of aging, in light of aneuploidy, and go from there.
Great, thank you. And if anybody wants to participate, you can raise your hand or put in a question in the questions panel, and we can start answering questions submitted today during the presentation. I have one currently, or a couple that are coming in right now, some of the questions. One that says, thank you for the wonderful speech. In our country, after 2 pregnancy losses, lots of doctors start aspirin and heparin without any panel. Would
Mhm.
you stop the drugs because there is no indication to continue or continue?
Hmm. So again, my answer is going to be it depends. So um, I don't give aspirin and heparin after two losses personally. I don't think there's anything wrong with giving aspirin, and also it depends on how old the patient is. So now in Canada, I'm not sure if you guys have similar guidelines, but for all pregnancies around 40 for the entire pregnancy, we're suggesting they're on low dose aspirin. Fragmin I don't routinely give. But again, empirically, does it cause patients harm? I don't think so. Um, and it just depends on why would you give it? Is it because you're suspicious of a vascular issue? Are you suspicious of an autoimmune issue? My empiric treatment is progesterone and early pregnancy monitoring. And if we're not successful, I try really hard to get tissue diagnosis because that'll help decide what our options are. If tissue diagnosis is obtained and it's genetically normal, that's when I would consider adding things like empiric fragment or heparin. If comes back and the tissue is genetically abnormal, then I would gauge the patient where they are in their fertility journey. If they can cope emotionally, if they're within their buffer of being able to cope with trial and error, then we try. We give them supportive care and we try. If they say to me, I can't deal with another pregnancy loss, or they're older or they want a big family, that's when I might consider genetic testing and PGT, IVF and
Thank
PGT.
thank you for the answer. I do have somebody that responded to your question of what would you do. The participant wrote, I would perform hysteroscopy and also check AMH level and endometrial culture for microbiology.
Yeah. So more diagnostics. I think those are all good answers
Mhm.
because they were not done. Um, And hysteroscopy, I'm not sure. Like if you look at the data, it doesn't add much when there aren't any other abnormalities found. But I think that's reasonable. AMH, I think is important because again, she's 36, she's advancing maternal age. She wants a big family. And she's already had three losses. So again, if you wanted to offer help and manage this patient to the best you can, you might want to consider ART, and therefore the AMH would be helpful.
Thank you. We have a few questions. The next one is, are you doing routine EMB for RPL to look for endometritis?
Am I? Yes, I have been. I was trained to always check for endometritis. So before I was looking at the microbiome, I was looking always for CD138 presence or plasma cells. If we found them, I would treat with levo and flagyl, but I don't necessarily do a test of cure.
Thank you. The next question is Lovenox a safe substitute for heparin for a patient with factor V Leiden?
I don't know. I think that's a question more for hematology. As far as low molecular weight, Lovenox and Fragment are probably equivalent if you're using them empirically, but I'm not sure in to actually treat factor V Leiden. Yeah.
Thank you. The next question is how long after a miscarriage can a patient bring in products of conception for testing, and how should it be stored?
So it should be stored in the fridge in a plastic container, no saline, no dilution. As long as it's in the fridge, the tissue can be kept sort of for a week or two. But now with the tissue collection kits that are being transported to your patients, it's just a matter of collecting it, keeping it in the fridge, and then putting it in the FedEx bags and shipping it off. So it's pretty quick. But as long as it's in the fridge, as long as it's not put in anything, it could be kept for probably a couple of weeks.
The next question is there any research on recurrent missed miscarriages versus symptomatic miscarriage?
No, not that I know of. It's a question, like I'm sure you're asking because you've had patients who've come in that have had non-symptomatic pregnancy losses and not been aware of it, and things just stop growing, but yet they don't actually have a loss. But it's interesting. I had not seen any work on that.
The next question is how often should an AMH level be checked?
So typically, I mean, if we look to some of the work that was done during COVID in patients with advanced age, you could see changes in AMH within a 3-month period. However, in clinical practice, I usually repeat it only once a year, um, unless you're gearing up for treatment or ART and you want to adjust the dose. If you practice like that, you might want to um, do it more frequently, but I think once a year is fine. Hopefully, they're not still with you within a year, so just once.
Thank you, Dr. Sierra. That was actually our last question. So I wanted to thank you and thank everyone for attending today's webinar, Recurrent Pregnancy Loss. If you have any other questions, you can contact myself, Alyssa Cooper, ecooper@bostonivf.com. Once you leave today's webinar, you'll receive a survey on the presentation, and we would appreciate it if you could complete the survey, provide your feedback to help with future educational webinars. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. On behalf of Boston IVF, Trio Fertility, the EVRMA North America Network, and Dr. Sierra, thank you for joining us and enjoy the rest of your day. Thank you, Dr. Sierra.
Thank you.